Welcome everybody and welcome to another APSAD Insight webinar. My name's Jim Hunt, I'm one of the nurse educators here with Insights. To start with, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today. I'd like to pay my respects to elders past, present and emerging, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us on webinar land. So welcome and thank you for joining us. Today, it gives me great pleasure to introduce a friend of mine, Dr. Karen Lee, who's a clinical psychologist who works here at Insight, and she's joined by Jillian Bleazby. And they're going to do a presentation today on helping women quit smoking during pregnancy. So I think it's quite a valid presentation, and it's going to be useful for a lot of clinicians. So without any further ado, please welcome Dr. Karen Lee.
Thanks, Jim, and we too acknowledge the traditional owners of the land on which we're standing and also the land on which you're meeting. So Jill and I are team leaders at Queensland's Quitline, and today we're going to cover a few topics with you. So firstly, we're going to start off with the prevalence of smoking in Australia, look at how to do smoking cessation in pregnant women, how to assess nicotine dependency, the pharmacotherapy options that are available to women, including how you would actually talk to them about the intricate nature of the use, and how to refer to Queensland's Quitline. So to start off with, we want to know, like, what is the prevalence of smoking in Australia? Is it even a big deal? Well, it kind of is. So from our last statistics, we know that about 11% of women above the age of 18 smoke on a daily basis. That's pretty good though, in comparison to the rest of the world. So if we look at Greece or Turkey, their rates are around 27%. We're even doing better than our neighbours in New Zealand who, you know, have 13%. So that's one thing we're beating them on. And when we look at the longitudinal nature of this, we can see that smoking rates in females of childbearing age have reduced over time. So, you know, around the age of when I was born, I won't reveal to you how old I am, but the rates were around, you know, 20 or 30% of women in those days were smokers. Why is this a big deal? Well, you know, at any point in time, women childbearing age could fall pregnant, and they might not know it for a while. So the exposure to the unborn child continues until they know. And most women are aware of the research now around the dangers of smoke exposure to their unborn child, and they try to spontaneously quit. So this is actually a really high quit attempt rate. 45 to 50% of women would attempt to quit during their pregnancy. But still, when we look at, you know, the number of women who smoke at any point in time during the 9 months of pregnancy, still 10 to 11% would still be smokers. And even if they did quit, 50% would relapse within the first 6 months and 80% would relapse within the first 12 months. So not only should we focus on supporting women of childbearing age while they're pregnant, but it's also a good opportunity to help them quit and stay quit postpartum. Another interesting statistic that I wanted to throw out there for the purpose of this presentation is that the rates of smoking in Indigenous women is significantly higher during pregnancy. And there was an ABSAD Insight, there was an ABSAD webinar about this early last month. So 45% of Indigenous pregnant women were found to be smoking in Australia. So should women quit? Yes, but why? So early last year, you would have, early this year, you would have seen the launch of the Safer Baby Bundle. And one of the pillars was to help women quit smoking in order to reduce the rates of stillbirth. So that we know that there are many harms associated with smoking for pregnant women. So there's a risk of miscarriage is higher, low birth weight. There's a risk of sudden infant death syndrome, or COT death as we colloquially know it, as well as low birth weight. But besides the kind of physical damages of smoking on both the woman and the child, we know that there are wider scale psychosocial benefits of quitting. So, you know, gone are the days where it was cool for someone to blow in your face with cigarette smoke. now when we walk past smokers, we almost have like a look of disgust, and it's quite stigmatizing and a lot of judgment associated with smoking still. And even more so when a woman is pregnant and we walk past them or we see them smoking, there is a lot of pressure on that female to quit smoking. And it's not easy for them either, which we'll talk about later. So not only are there short-term benefits of quitting, we talk about more longitudinal benefits of quitting. And some of the research has shown that, you know, when a woman is struggling to quit and can't quit during a pregnancy, it has impacts on their way of nurturing their child. They're more likely to use physical punishment. And also there are high levels of family conflict that exists. This then, I would believe, leads to a reciprocal effect over time where there is more conduct disorders in the child. And also we know that teenagers are more likely to smoke if their parents smoked during the early years of rearing. Some of the other psychosocial benefits of quitting smoking is money. Did you know you could save, you know, if you were a pack a day smoker, you could save about, you know, a small car by the end of the year if you had quit smoking. It's not cheap. And diapers and baby wipes, all these things are quite expensive. I had the privilege of listening to a Quitline call recently where the mother was able to quit and was able to, you know, decorate the nursery. And this was quite a lovely experience for the mother. Why is it so difficult then for women to quit smoking during pregnancy? Well, it's difficult to quit in general, but there are some of these myths or things that women would consider. So some of my callers would tell us, you know, smoking helps me manage my stress. I have to smoke because, you know, pregnancy is quite stressful. Well, actually, they're right, because when there is cravings or withdrawals, that produces a lot of physical stress on the body. And as soon as they smoke, man, there's a feel-good factor. But that's just alleviating the withdrawals. In the long term, it doesn't remove the overall level of stress. It doesn't remove any background psychosocial factors. What we know from research is that if someone is able to quit smoking, their physical and mental well-being is actually improved over the longer term. And they do actually find alternative ways of coping. So for instance, they learn to do mindfulness or other hobbies or speaking with friends or so on. Oops, just trying to catch up with my slides. The other myth that we often hear about is the worry about putting on weight. And already, you know, a female puts on weight during pregnancy, but also when you quit smoking, the metabolism returns to normal. And women can gain up to 5 to 10% of their body weight in some instances, but usually around the 2 to 3 kilograms in the short or long term. So alternative coping mechanisms that we can equip women with include, you know, nutrition guidance, physical activity and lifestyle factors. What we do know is that a person would have to gain a fair chunk of weight to outweigh the benefits of quitting, so about 42 kilograms. Another myth that we often hear is it's just so hard to avoid smoking when everyone smokes. So, you know, these pregnant women would have other family members that who smoke, or they're exposed to colleagues or friends who smoke. So simply we equip them with assertive communication skills or skills around, you know, having house rules where you're not allowed to smoke in the car or not allowed to smoke in the house. Having conversations with their friends and family about how they can support them during the quit is also important. So we know that there are priming effects associated with second and third hand smoke, where the body anticipates the nicotine intake and actually draws a woman into more craving. So to talk to the family and friends about, you know, can you smoke outside or can you smoke somewhere else while I'm around is actually a really helpful thing for pregnant women. It's also easier nowadays to catch up with people in smoke-free areas. So we know most parks and public places have smoke-free zones, and it makes it easier and less stressful for women while they're undergoing their quit. There are also other things associated with the pregnancy that makes it really difficult to quit. We know that for a vast majority of the women, it's their second child that they're having where they're attempting their quit. And it's really difficult to manage several children under the age of 5, and also household chores and their work and everything else, and in order to get themselves into like a 45-minute appointment with a GP or a midwife, or even talking to Quitline. Having that time set aside for that service becomes very difficult for women. And the other thing which Jill will talk about later in today's presentation is that the nicotine is cleared in the body much quicker in pregnant women than in women and than in men. And so the dependency, the physical dependency on nicotine becomes much stronger. So a 60% increase in nicotine clearance in women, and a 140% increase in continine clearance. So we know that it's important for women to quit smoking. We know that it's good for them, and we know it's difficult. But how do we support them? Well, we need to identify them. We need to know who they are. There's quite a bit of reluctance in most healthcare professionals or midwives or even psychologists like myself to actually ask about smoking, because there's the myths or the fears that if I ask about it, then I need to treat it. And I don't know how to ask, and I don't know how to treat. So what do we need to do? We just need to ask. They expect us to ask. And it's not hard to. So one of the tools that was developed by Quit Victoria and published by the Royal College of General Practice last year is the free AIDS model. It's really simple. All you have to do is ask. In a non-judgmental tone, do you currently smoke? As a matter of fact, as if you're doing any other history. You record the smoking status, and then you ask, have you smoked in the past? If they had said no, currently. But if they do smoke, you advise them. So the most important thing you can do for your health is to stop smoking. It's really much easier to stop smoking if you've got some kind of behavioral intervention or some pharmacotherapy support to help you, and to link them in with further supports or helps. So whether it's a referral to Quitline, so you can refer to Quitline online, or people can self-refer. We often prefer that people are referred in because we make proactive attempts to contact people. We can link them in with tools, and we'll show you some of those resources later in terms of websites and apps and print resources. And we can encourage our clients and patients to use nicotine replacement products, which we'll talk about later as well. One of the other tools that have been used in clinics around Australia and around the world is Smokerlyzer. So what someone would do is they would breathe into the Smokerlyzer, and it will give them a carbon monoxide reading. The great thing about the ones that are designed for pregnancy, it shows the impact on the fetal development. I'm going to show a little bit of a video now to demonstrate its use and how one would talk to a consumer about using this.
Carbon monoxide is known as the silent killer because it is an invisible, tasteless and odourless gas that is formed from incomplete combustion, such as house fires, car exhaust fumes and smoking. Oxygen is carried around the body by red blood cells, and when you inhale smoke from a cigarette, the CO is absorbed into your blood through the lungs. Because CO binds with hemoglobin 200 times more readily than oxygen, your body is starved from oxygen. This leads to many health complications and smoking-related diseases, such as a higher risk of stroke or heart attack, shortness of breath, and poor circulation. The Pico Baby Smokerlyzer has been specifically designed for midwives to help mums-to-be quit smoking. It works by non-invasively measuring carbon monoxide on a smoker's breath and also calculate the amount of CO that is affecting the unborn baby. To take a maternity breath test with the Pico Baby Smokerlyzer, first attach the D-piece to the monitor and then the SteriBreath to the Pico Baby. Click on the maternity breath test icon to begin. You will be asked to inhale and hold your breath for the preset 15-second countdown before slowly blowing into the Pico baby. The reading will rise and stabilize on screen, and you can choose to mute the monitor if necessary. Here, you will also see the fetal carboxyhemoglobin calculation, which is the amount of harmful CO affecting the unborn baby. When the test is finished, click the home icon to return to the home screen. Readings and results can be interpreted using the maternity Smokerlyzer CO chart.
So the CO monitor can be particularly helpful in used in a clinical setting to give some feedback to the patient about not only their self and their CO levels, but also that of their baby. So it can be a very tangible way to measure, obviously CO, but also give some sort of an indication about how this is actually truly playing out health-wise on the baby. That video there actually can be accessed through Dovetail as well. And it just goes into a bit more information about the general use of CO monitors. So it's a good one to have a look at as well, but we won't go through that today. So what is nicotine dependence? And this is obviously very important also for our patients to understand what's actually happening for them. So nicotine is the addictive substance found in tobacco. It mimics the naturally occurring chemical messenger called acetylcholine. This attaches to the nicotine receptors in the brain, or nicotinic acetylcholine receptors, and activates the reward pathway, releasing feel-good chemicals such as dopamine, serotonin, and that gives that pleasurable response. This happens particularly quickly in about 10 seconds. And that's why it can be, particularly addictive, is that you're getting that immediate hit. If we smoke for a period of time, what we notice is that our brain then adapts to that, which is called neural adaptation. So we start off smoking nicotine and getting that feel-good hormones, dopamine, serotonin, and the brain says, oh, we're getting heaps of this, I need to adapt. And what happens is those receptors do multiply over time. With the receptors multiplying, this is associated with an increase in tolerance, so therefore the person needing more nicotine to get those pleasurable effects. And a level of dependence. So if you don't have the nicotine, you start to go into withdrawal. And it is the withdrawal symptoms that people are trying to avoid when they're quitting smoking. This vicious cycle is called negative reinforcement. So we start off with the nicotine pleasure for enhanced mood, and then you start to build up a tolerance of that brain changing. And then you start to, if you don't have nicotine for a while, and it happens pretty quickly, like within about 45 minutes, that you can start to go into nicotine withdrawal. Then you sort of self-medicate by having cigarettes again to boost up those levels, to feel good and to manage those withdrawals, and then you're stuck in that vicious cycle. So it can be very tricky to get out of. What we like to do is we like to give our patients a bit more of an understanding by showing this fantastic video to them. The little green monster is a really easy to understand video, and we often at Quitline just text that to our clients. They can have a look on their phones, and it helps them to better understand what's happening in terms of their nicotine withdrawal and the nicotine cycle.
People start smoking for all kinds of reasons, like peer pressure or weight. But they continue to smoke to avoid the withdrawal symptoms they get when they don't. They get irritable, can't concentrate, and want something to take those symptoms away. They puff on a cigarette and the symptoms disappear. This is called the negative reinforcement of smoking. Smoking takes away the unpleasant or negative effects that come about when people don't smoke. This is an important idea to get across to people when they are quitting. An easy way to express the process of negative reinforcement is the analogy of the little green monster on the shoulder. Over many years of smoking, you have developed a little green monster on your shoulder. It gets hungry and wants nicotine. If you don't smoke for a while, it gets hungrier and hungrier and starts screaming out, "Feed me! Feed me!" The way that smokers deal with it? Have a cigarette. You have a nice relaxing puff and everything goes away. The monster is quiet and goes to sleep for a while. But within an hour or two, the monster is getting a little bit hungry again, shouting, "Feed me! Feed me!" And you have to go out and have another cigarette, just to shut the monster up. Nicotine is carried on cigarette smoke into the lungs, where it enters the blood and travels to the brain. It takes about 30 seconds from taking a puff for the nicotine to reach the reward pathway in the brain. Our brains have a reward pathway because it's essential for our survival. There are certain things we must do, like eating and reproducing. Our brains reward us for doing these vital things with pleasurable sensations. Smoking is addictive because it contains nicotine, and nicotine exerts its addictive properties by hijacking this reward pathway. This reward pathway can be seen as a circuit. Having a puff flips the switch and the smoker gets their reward. Neurotransmitters are chemicals that the nerves in our bodies and brains use to communicate. To the brain, nicotine looks exactly like one of these neurotransmitters. Like a wolf in sheep's clothing, nicotine mimics these neurotransmitters and tricks the brain into triggering our reward pathway, and bingo! Nicotine binds to the switch part of the reward pathway on things called neural receptors. In response to the constant supply of nicotine, more receptors grow on the nerves over time. The growth of the new neural receptors is called neuroadaptation. Literally, the brain adapting to a change in brain chemistry. Over the first few days and weeks of not having a cigarette, the monster is going to be pretty upset. But the longer it goes without a single puff, the monster gets weaker and weaker until finally it falls asleep. But the little green monster is only asleep. It's not going anywhere. It's just having a snooze, ready to be woken up by a single puff of a cigarette. One puff, just one little puff, will light up the reward pathway and the monster will wake up and wake up hungry. Giving up smoking is not easy. The more people understand about what is happening in their body, the better they are able to cope with the symptoms of nicotine withdrawal and stay cigarette-free permanently.
So as I said, that one can be a really useful video, particularly if you don't have time during clinic to actually go through some of this in detail, is to give your patient this to take home and watch, and also show their family and friends about what's going on when they're about to go through nicotine withdrawal. One of the important things that Karen brought up before was the issue of nicotine metabolism in pregnancy. Research has shown that nicotine metabolism does increase during pregnancy. So when you are pregnant, metabolism in general does increase for a lot of different compounds, but nicotine has been now shown to be one of those compounds. And we can see here from this graph that during the pregnancy period, and they measured from weeks 8 to 36, we could see that the nicotine metabolism really did rise in that time. And then after the delivery of the baby, it dropped back again to regular levels of what they were smoking previously. And it remained constant then after that time as well. Now, this is a particularly significant finding when we look at treatment for nicotine replacement therapy. With treatment for nicotine, often we are using nicotine replacement therapy, and we need to be able to tailor that to the level that the pregnant lady is needing, which does increase during that time. So how can we help? Well, the same still applies, I guess, for our pregnant population as it does for our general population. And one of the best ways, I guess, of quitting smoking is to use a combination of pharmacological intervention and behavioural change support from a health professional. What does the research show though? So in the general population, there's some really strong evidence around these first-line therapies such as varenicline, bupropion and nicotine replacement therapy. Those products have been shown to more than double the smoking cessation rates. However, when we look at the pregnancy population, we're not seeing exactly the same results. So there's a bit more low certainty in the evidence around this population. We are seeing though that nicotine plus behavioural support might be effective in helping this population to quit smoking. We are seeing that nicotine replacement therapy is more effective than a placebo for this population. And we're seeing that in human trials for nicotine replacement therapy, that nicotine replacement therapy does not seem to be harmful to the baby. So why does nicotine replacement therapy seem to be less effective in pregnancy for women? Well, one of those things I already talked about, and that's the metabolism. So are we underdosing our women when we are initiating nicotine replacement therapy? In the trials, a lot of them are using a 15 milligram patch rather than higher doses or even combination therapy. And given that when a woman becomes pregnant, that her metabolism of nicotine increases, so her level of nicotine is being eliminated from the body even more quickly than what she was prior to the pregnancy, in effect, that makes us think, well, maybe we need to use more. The other issues that might also be happening in the research is the treatment adherence, that often they were finding that adherence to treatment was just not as good as what they were seeing in non-pregnant populations. We were seeing a bit more incorrect use of nicotine replacement products, inadequate dose, as we've already discussed, and inadequate treatment length. So usually the treatment length would be around 8 to 12 weeks, and we're seeing that women were only maybe trying out or trialing nicotine replacement therapy before actually dismissing it. What do the clinical guidelines say? So in Australia, according to the Royal Australian College of General Practitioners, they recommend to initiate NRT in pregnant women who have been unable to stop smoking unassisted. And generally by the time we see women in clinic or whether we speak to women over the phone at Quitline, they've generally tried to quit prior. So when we're seeing them, we usually start to have the conversation about using nicotine replacement therapy. During this conversation, we talk about the relative risks of that versus the benefits. And we're always considering these things in the context of smoking cessation. So what is the woman already doing? They're already smoking cigarettes. They're already exposing themselves to nicotine and higher levels of nicotine than what you'd get from a cigarette, what you'd get from nicotine replacement therapy. And also those 7,000 plus chemicals that you'd get in cigarette smoking. So the guidelines actually state that you start with an oral form of nicotine replacement therapy first and start to titrate up. And if that's sort of not working, then you can go on to using a nicotine replacement patch as well. So the aim of nicotine replacement therapy is basically what the name suggests, is providing the body with a bit of nicotine so that the body doesn't go into withdrawal. But it doesn't deliver the 7,000 harmful chemicals that you'd otherwise get from cigarette smoke. It's at a lower dose and it's slower delivery, and that's important as well. So that's less issues with dependency because of the slower delivery. In general, monotherapy, so just even using just one form of nicotine replacement therapy, can increase the quit rates by about 50 to 60%. Combination NRT, so using a patch plus oral form, increases it even further. And using higher doses, so using your 4 milligram gums as opposed to your 2 milligram gums, are going to give you better results as well. These are some of the nicotine replacement products available. So you've got the nicotine replacement patch. We've got, in the oral forms, we've got the gum, the lozenge, the inhalator, and the mouth spray. The mouth spray does contain a tiny bit of alcohol, so that might be consideration as well in terms of its use. How does it work? A good way to demonstrate this, particularly to clients as well, is to basically draw out a little bit of a roller coaster for them. So what's happening when we smoke cigarettes, we are getting a constant high and lows throughout the day. High when we have the cigarettes and get that nicotine reward hit to the brain. And then quite soon after, within sort of 45 minutes, we start to get those lows. And then we feel withdrawal symptoms, irritability, lack of concentration, restfulness, all of those type of things. This graphic here sort of demonstrates if you're wearing a patch or using oral nicotine replacement therapy effectively, and that's by using it constantly to achieve and maintain a stable level. So the green bar there kind of cuts through the middle of that roller coaster. It sort of suggests that you're not getting those highs that you would from smoking a cigarette. So you're not getting those big hits of nicotine to the brain, but you're also not going into those withdrawal effects either. So you're on a bit more of a manageable platform. Over time, over about 8 to 12 weeks, what we're seeing in those receptors is they start to effectively get a little bit bored with that situation. So they're neither getting those highs or those lows. And over time, we tend to tell our clients that they go to sleep. Basically, the receptors go to sleep in the brain. They don't go away, but they go dormant or downregulate. So the important thing, I guess, there to remember is once you get into that process where your receptors have downregulated and gone to sleep, that you wouldn't have one more puff, because one more puff would be enough to wake up those receptors again, and then you'd be back on the start of that roller coaster. So I'll hand back over to Karen now, who will explain how nicotine replacement products work.
Thanks, Jill. I've got some show and tell, so partly gonna try to balance some of these things and show you what they look like in real life, and we've also got some pictures on the screen. So nicotine patches work by slowly releasing nicotine in the body through the skin. It's actually in a sealed package. It's quite childproof, and you can't really open it without scissors, so that becomes quite useful, especially if there's other children at home. The aim we tell the patients to do is just to put it on a clean, relatively hairless part of the skin and rotate that through the body. Keep it on for 24 hours. And for people who are not pregnant, but for pregnant women, we advise removing that before bedtime. The research isn't clear about why, but we take a more conservative approach where we're reducing the nicotine exposure overnight to the fetus. For some women, especially when we talk to people from far north Queensland or the more humid parts of the state, they have really a lot of difficulties keeping the patch on. So we talk about, strategies around whether we need to put some sports tape over the patch just to keep the patch on, or we talk about, some creative strategies of using socks or things, or what parts of the body to put the patch on. If they're feeling some kind of mild allergic response to the actual adhesive, not the nicotine itself, but the actual plastically gooey stuff that goes onto the patch, we talked to them about whether they need to consider mild steroid creams through their pharmacies, or even antihistamine sprays that they can spray on the patch before they apply them. And it doesn't actually affect the patch adherence. So oral forms of nicotine replacement therapy. There was a question earlier in the chat about whether short or long lasting nicotine replacement therapy is more useful. Well, the Royal College of General Practitioners would suggest to use orals first in the first instance, because of the fast nature of clearance of nicotine in the pregnant woman. You'd probably want to replace cigarettes with the oral nicotine replacement therapy when you can. But if you can't, you also add the patch with the combination therapy that Jill talked about. So the nicotine itself in oral products is absorbed in the mouth lining. It's no good in your stomach. It's just going to cause stomach upsets or even hiccups. So we recommend that women don't eat or drink while using the products, either gum or lozenge or inhalators and so on. And even before and after would be useful, because the saliva would bring the nicotine down into the stomach lining. The oral nicotine replacement therapy is to really address some of these breakthrough cravings. So sometimes we would advise patients to recognize what the trigger points are. So for some women, it's, they've had enough time at home and they really need to leave the house and they know it's a trigger for them. So putting in the nicotine replacement product in their mouth before they go and take that break elsewhere would be a strategy that I would recommend, to marry those behavioural and pharmacotherapy strategies together. Let's start with the first one. So the most common one we can get on the market, and probably the cheapest one you can get, is nicotine gum over the counter. It's in these blister packs. You can take them out, and I don't know if you can see them, but they're like the size of a regular piece of chewing gum. The problem that most consumers get when they buy products over the counter is they're not using it properly. So I'm not going to put it in my mouth because it actually contains nicotine. But the idea is that you'd put it in your mouth, you'd chew it, and it will release a fairly unpleasant flavour if you're using the classic gum or whatever flavour that you've purchased. You'd feel the flavour, and then you just park it. The nicotine gets absorbed in the mouth lining, and then after a while, it will not taste like anything again. So then you chew it and you park it on another part of the mouth lining. It's called the park, chew, park method, or chew, park, chew. It really does matter. But the idea is it's in the mouth lining. If you chew it repeatedly and expect something to happen, it's not going to happen unless it's parked in. And the rate at which you're digesting that or getting that into your body is probably not the rate we want. After you finish chewing the piece of gum, there's still going to be nicotine in it. Even after all the flavour runs out. So it's really important, if you've got other children at home, to really safely dispose of that piece of nicotine gum. The next product that I want to talk to you about is the Nicotine Lozenge. These are relatively simple to use. The pack's a little bit child resistant, so it's a little bit difficult to open. I've opened it before, but there's a little bit of a tab, and then you can get the thing. Oh man, so difficult. Which is good. You can get the stuff out, and it's the size, it varies in size depending on what you get, but it's fairly small. I would describe it like almost the size of a Tic Tac. Again, you put it in the mouth or underneath your tongue and it will dissolve. It's much easier, this one. You don't need to remember to chew it or do anything with it. It will just dissolve. The gum lasts for about half an hour. The lozenge, depending on the rate of salivation and how it's absorbed, 15 to 20 minutes. Then we have the inhalator. This one's a little bit more expensive on the market and a little bit more difficult to use, but it's good because it allows you to replace the hand to mouth motion. So when we talk to pregnant women, they actually quite like this one. It's a little bit difficult to explain over the phone, but it's nice if you have one of these in your clinic to actually kind of show them the use. You need to line up the markers to be able to take out the tubing. And then you'd remove one of the cartridges from a blister pack. From my perspective, it doesn't really matter which side you put in because you put it into the actual device. Oh, I've already got one in here, so I need to remove it. And then you'll hear it break. When the seal breaks, there's actually nicotine that's in the system now and it's open. And what you want to do is not smoke it like a cigarette. If you inhaled it as a cigarette, it's not going to go into the mouth lining where all oral nicotine products are actually absorbed. So shallow puffs allow the nicotine to absorb in the mouth lining, or too deep puffs. Again, the same idea. Cartridges, when used consistently, will last for about 40 minutes, but you can kind of puff on it a few times and leave it. Puff on a few times and leave it. And it might last for some people across the span of a day. For others, it might last for less time. The idea is you can keep using it when you can still taste the nicotine. You'd probably want to replace a cartridge once a day as well, just to make sure it's all hygienic, and you can clean the plastic bits of it. And each packet comes with a new plastic tubie. Again, it still has nicotine in the device itself, so make sure you clean it and keep it out of reach with children. The last product that I want to show you is the nicotine mouth spray. Again, Jill talked about earlier that it does contain alcohol. So you need to explain the risks and benefits for women, but this is probably the fastest product to reach the brain. So it's a little bit difficult to open there's a little bit of a press and move situation. So it's even difficult for me, but then you spray it. So in the ads, it will show you to spray directly in the mouth, but that's not going to go where we want it to go. So we want to spray it inside the mouth lining or underneath the tongue. 1 to 2 sprays each time you do it, maximum 4 an hour. And the idea with any of these oral nicotine products is to use them instead of smoking. And it's better than smoking for the pregnant woman. I'm going to hand it back to Jill, who will talk a little bit about the conversation we'll have with women about smoking cessation treatment.
So how do we have that conversation with women about smoking cessation? So we've talked first about how to ask about it and get that conversation rolling. Some of the things that often clinicians we forget is that, you know, we need to have a conversation about quitting smoking. And women expect to, and they appreciate actually having that support to quit smoking. So in effect, having no conversation about quitting smoking potentially equals my behaviour is okay. So asking each time, even if you've asked before, ask again in a supportive, non-judgmental way, how are you going with this smoking? What sort of help do you need from me to be able to stop smoking? So using reflective type communication, that's your paraphrasing, your open questions, just being quite open to hearing the woman's story about her journey through smoking and quitting smoking. What has she tried before? What's worked? What hasn't worked? What are some of the current barriers that she might face to being able to make some changes with her smoking? So always ask as well before providing information. Often as clinicians, we can, you know, get into the role of just giving out heaps and heaps of health information. As we talked about before, women tend to know the basics around smoking and it's not good for the baby and things like that. So it's more about asking the patient what they know. So what do you know about the effects of smoking? What do you know about the effects on your baby? And what do you think might be the good things that you might get out of being smoke-free? Ask what they're looking forward to. And then going on to have a look at what are some of the challenges that they might experience and what sort of small steps can we take. And I think that's one of the key points as well. Taking small steps, behavioural change, can be less daunting than if we say, right, you need to change all of these things up, which have been, you know, part of the woman's routine for years and years and years. So at Quitline particularly, we would have a talk about identifying some of those triggers, so the common times that the pregnant lady would smoke, and then working out some alternatives. And often the things that we hear is, yeah, I smoke to relieve stress, I smoke because others around me are smoking, I smoke because it's just a habit and a thing that I do. So we have a look into some of those things and talk about both what we can do to manage that physical dependency. So that's one side of your smoking, and using NRTs can be effective in doing that. And the other side of the smoking, which is about those habits and routines. How can we look at those things? What sort of the role is cigarettes playing in your life? And how can we achieve that in a different way, in a healthier way? It's useful to provide a risk and benefit assessment of nicotine replacement therapy as well. So not only often do clinicians present as being probably a little bit maybe intimidated about recommending nicotine replacement therapy, and rightly so, because the messages out there in the research are still a little bit unclear about that. But also for our pregnant lady who's been told, oh, don't take this, don't take medications, whatever, and we're saying, oh, take this medication. So sussing out where the lady's at in terms of how she feels about the nicotine replacement therapy, and working out how likely she will be to carry through and start to use some of these products. And of course, you know, we don't have endless amounts of time in clinic to have long conversations about certain things, because there's so many things that we need to get through. So referring off to your specific smoking cessation clinics, or to Quitline, or to your local tobacco treatment specialist is going to help carry on that information. So I just want to refer you now to a narrative study by Bleazby and colleagues, which has an excellent clinical overview on how to approach quitting smoking in pregnancy. One of the things that they recommend, and what I just spoke about earlier, is having a conversation about that risk and benefit of using nicotine replacement therapy. So having that will just iron out any concerns that the pregnant lady might have about using NRT, and I guess encourage, the benefits of using nicotine replacement therapy. So we know in animal models that nicotine has been shown to cause some effects, cognitive impairment, impaired lung development, preterm birth, those sort of things. But for nicotine replacement therapy, we're not really seeing that in the studies that have come about. And always this is discussed in the context of smoking cessation. So thinking about what is the woman already doing? If they're already smoking, then we're trying to, cut out that level of nicotine that they're already using, plus the 7,000 harmful chemicals that they're inhaling, and replace that with a safer method. And it's a short-term method in order for them to become smoke-free. So some of those benefits there are obviously non-exposure to the chemicals. Nicotine is absorbed at a slower and lower rate, so the risk of dependency is a lot less or nil, and it increases the rates of quitting smoking up to about 40%. From the same study, they've outlined a little bit of a table here of how to approach, which is quite similar to the RACGP guidelines. So initially starting off and trying to quit without anything, and if the woman hasn't been able to do that, then to commence nicotine replacement therapy. In this study as well, interestingly enough, they would utilise your phagostrom dependency, which is the three main questions in that we use at Quitline. How many cigarettes do you smoke? How long after waking do you have that very first cigarette? And do you experience withdrawal symptoms? What we notice with our pregnant ladies is they've already tried to cut down. So sometimes that how many cigarettes are you smoking may not be as reliable as it was. So unless you're saying how many cigarettes did you smoke prior to knowing that you were pregnant, those type of questions. Another way of looking at that is to have a look at urges or cravings. Have a look at the strength. So asking the lady, how strong do you feel your cravings are throughout the day, and how frequently do you get these urges to smoke? And they can be a really good telltale as well about the level of dependency of the woman. Of course, time after waking is an excellent way of working out dependency, and we know the sooner that they have a cigarette after waking, or they potentially might even wake up through the night and have a cigarette, the more dependent that they would be. So the need to use nicotine replacement therapy there. So like the RACGP guidelines, we start off with an oral form of nicotine replacement therapy. We use a higher dose there, so the 4 milligrams as opposed to lower 2 milligrams. And we see if that knocks out the cigarette smoking. Then we revisit the urges, so how strong are your cravings, how frequent do you get your cravings. And then if we're still smoking, we're still experiencing high levels of urges and cravings, which indicates withdrawal symptoms, then we would use a patch on top of that and commence with the patch. We do use a conservative approach, and we take the patch off at night just to give the body a little bit of reprieve from any form of nicotine. So how will Quitline assist my patient? And I'll hand that back over to Karen.
So we don't have much time. I'm going to be really quick on this, but in general, when we read a Cochrane review, it usually recommends that more evidence or more research is needed. But the great thing about Quitlines around the world is that the conclusions from the last few Cochrane reviews, the last one was published in 2018, sorry about the dated reference, that is that we do not need any further research. We know that Quitlines around the world are cost effective. they're accessible. So people in the Torres Strait Islands can access our services. People in rural and remote Queensland are dialing in. We know that Quitline increases quit rates. So some of our preliminary research would indicate that, you know, when a pregnant woman is able to complete a program with us, 50% of those would achieve quit within that 4-core program. And these rates drop off a little bit over time, but at 12-month follow-up, we get nearly 20% who remain quit, which is phenomenal given the rates of quit of other substances and unassisted quit rates around the world. We also advise about pharmacotherapy use. So in our Quitline in Queensland, we talk to people about the options around the PBS. So women can access one form of nicotine replacement product at one time. So whether that be patches or gum or lozenges, these are the only products on the PBS at the moment for pregnant women. Quitline in Queensland is open every day except for Christmas. It's part of Queensland Health. It's a confidential and evidence-based process, and each call is unscripted. It's a call between you and a counsellor. They determine your individual process and your individual situation and really tailor support for you. We've got a dedicated team of Aboriginal and Torres Strait Islander counsellors, and we're from a range of different backgrounds. So there's counsellors, there's social workers, psychologists, all walks of life, smokers, ex-smokers, and non-smokers. There's a few things that we cover in each and every call, including the nicotine dependence assessment, recommendations about pharmacotherapy depending on the rate of dependence at each call, and really look into, you know, why it is that a woman wants to quit and how we can create a quit plan together based on past quit attempts and introducing health information as part of that. At the moment, due to COVID, there is a program that runs across the state that supplies nicotine replacement products if relevant for consumers, but the eligibility kind of varies from time to time. Some of our calls are one-call programs, other calls have multiple calls, so other programs have multiple calls, and finally some of our programs include MRT, and that's determined by our funding bodies. There's a range of resources available if you click into the Quit HQ website. There's apps that clients can download. So My Quit Buddies for the generic population, but Quit for You, Quit for Two is funded by the federal government and provides really a nice way for pregnant women to interact with the app and say, you know, I'm not smoking this much, how's that benefiting my child? Thank you, and I think we only have a few minutes for questions.
Thank you very much, Karen. And Jillian, I should say, if you want to come and join Karen for the questions, I don't know, it's up to you guys if you want to do that. Thank you very much for an informative presentation. I know from the feedback on the chat room that there's lots of positive comments, and thank you for those of people that are watching. We have lots of questions. Before I start going through the questions, I just quickly want to say we record these, which includes the questions, so if you do have to return to your clinical practices because we run over, please go ahead and do that, and just remember to come back and watch the questions when it gets uploaded onto the Insight website. But for now, we'll just work through what we've got, so please bear with us, people. You mentioned a number of times about the safety stuff on the NRT products. What is the risks if children do get hold of it? How dangerous is the product?
One of the other team leaders wants me to say that it's children and pets. So it's nicotine exposure. So even if a woman is just smoking and there's passive smoke to the child, for a year that would be equivalent to 150 cigarettes. But the nicotine in these, it depends on the amount of absorption. Sure. Yeah.
And how much is consumed.
And how much is consumed.
You talk about the location of the patches. I've got a couple of questions regards that. Is there any effect if you put patches over tattoos, for example?
It depends on the type of patch, but for the ones that we supply or the ones that are on the PBS, the manufacturer instructions are saying that you should not put them over patches, over tattoos.
Okay, yeah. So find some clean skin, hopefully.
Clean skin, yeah.
Which leads to the next question. So obviously, as we talked about, the stigma around smoking, fortunately, is moving the other way. And, you know, if you continue to smoke now, the stigma's against you. Now, if a woman is trying to stop and she wants to wear the patch, but she doesn't want it on her arms because of that, you know, doesn't want it visible, what are her other options as regards location of the patches?
It's a really great question. Because you can rotate it across your body, and the more fatty the skin, the harder it is for the nicotine to enter the bloodstream. So some patches also are clear and translucent, so that might be an option, but bra lines, not a problem underneath the skin. I mean, underneath the clothing is not a problem as well. Any other comments, Jill?
We used to say anywhere above the waist is kind of accepted. Is that?
So other people, even in the feet, if they really can't get it to stick on, is also an option.
Cool.
Yeah.
Is there a actual daily dose maximum for pregnant ladies, pregnant women, regarding the use of NRT?
I think the use of NRT needs to be guided by the withdrawal symptoms. So the idea is that you use at least amount to manage the withdrawal symptoms is the trick. So if they're still smoking, still experiencing withdrawal symptoms, then I'd say that they're not getting enough nicotine replacement from to manage those withdrawal symptoms.
Which kind of leads to two further questions. You know, my background's in mental health, and obviously those clients also struggle in cessation of smoking. And one of the things that we were encouraged to do when people were struggling was multiple patches. Is that something that is approved in pregnancy?
I guess, again, it comes down to that bottom line. What is the person already doing? If they're already smoking, then they're already exposing themselves to high levels of nicotine. So you use as much as you need to manage those withdrawal symptoms. And obviously having that behavioural support there as well to assist the lady. But we don't find people using, like, the main problem is underdosing. So that is the absolute main problem. People are not using enough, not using too much.
Staying with dosing, just for the questions at the moment, and you've kind of answered it, I guess, in the discussion. But somebody's mentioned that on the packages, the NRT packages, they obviously have recommended guidelines as to how much you should take. If somebody requires more than that, how do you have that conversation around, you know, they're obviously concerned about overdose because the package says this and we're potentially advising higher?
We have a conversation about off-label recommendations, that the recommendations on the label are very generic and not everyone is the same in terms of their smoking. Some people will need more nicotine replacement therapy, and that's fine. So again, coming back to individualizing it for the client and working out their withdrawal and cravings, that's ultimately what's going to set the story.
You mentioned about taking patches off at night for pregnant ladies. If somebody, obviously, if you're a heavy smoker, you take your patch off at night, there's a strong possibility you're going to wake up during the night with cravings. How do you manage that?
The orals in the morning are very important. So for some ladies, they'll have to keep it beside their bed. So even before they're fully awake, they'll need to either put in a piece of gum or a lozenge or mouth a spray into their system so that the patch has time to take effect.
What are the costs associated with NRT, or at least I know it will vary depending on which chemist you're buying them from, whether it's prescribed, all of that, but a bit of an overview.
Sure. So some of these products are available through the PBS, so it would be your standard script rate. So $40-something for the general public for a month worth of patches, for instance, or if you're on concession card, it's less, or if you're on Close the Gap scheme, again, depends on whether you're concession or not on the Close the Gap. But over the counter in the pharmacy or in your local supermarket, we would look at, I'd compare prices because sometimes they go on sale.
Yeah, definitely.
But I'd look for the best price. We will find that patches is probably the cheapest thing on the market if you just buy it without any rebates, and the mouth spray and the inhalators would be more expensive in comparison.
And if I came to Quitline, how much is it going to cost me?
We supply it to eligible patients for free.
Perfect. Is there a limit to how long that would be for?
It depends on our funding model, so that changes from time to time. It's best to kind of call in and inquire if people are keen to quit.
And on that referral to Quitline point, somebody's asked, if I refer somebody to Quitline as a clinician, what's the time frame before them being either contacted and engaged? Because the comment said that many people don't are reporting that they're not hearing from Quitline.
That would be very surprising. Sometimes
Yes.
our turnaround is 24 hours.
That's impressive. That's impressive.
And sometimes they're like, well, I just spoke to someone about this.
And I'm guessing if a client is telling a clinician that, you know, that nobody's calling me, that you wouldn't have any issue with the client.
We attempt up to 6 times.
But the
to
clinician
call them.
can call you just to check that that has been happening. Is that something that's possible if they've referred somebody?
So clinicians,
lost, really.
Clinicians can kind of call in, and we can see what we can do.
Yeah. Usually any requests will need to be put in writing for obviously privacy reasons. Sure. So just flick through an email.
Sure. That makes sense. But I'm a big fan of making close connections with services so that you can you can get those issues resolved swiftly. Back to the NRT, one of the sprays I think mentioned that it contained alcohol. So how does that work in pregnancy? Is that one contraindicated, or is that because it's so small, is it acceptable use?
Risks and benefits. So this particular spray that I've got in my hand right now, 1 milligram of alcohol in the spray. Oh, sorry, 1 milligram of 1% alcohol. I think 1% alcohol. 1%. It's not much, but it's no safe level of alcohol use in pregnancy.
No. And I'm sure there may well be products that are in a spray form that don't contain alcohol. It wouldn't surprise me if those exist, but if not, there are many other pulsatile or, you know, NRT that isn't a patch form. So definitely have a look at options. Somebody's put Cochrane states that actually for nicotine dependence, MI doesn't hold, or motivational interviewing, I should say, doesn't hold great results. What recommended strategies do you use at Quitline?
So it's always an accommodation. So some of these studies that you find with the MI doesn't have as much nicotine replacement products. Actually, in pregnant women, most of the studies find it very difficult to show efficacy without NRT as well. So it wouldn't be in isolation that would be recommending that.
Thank you. When you were talking about the ask assessment process, you were talking specifically, obviously, about the pregnant woman. Somebody's just put in, which I think is a very valid point, that it's also important to ask the person about who else is in their household.
The family,
just so that there's, you know, it may be that everybody needs to go for NRT if potentially that's the situation.
And counselling.
On the benefits of the Quitline slide, you mentioned physical punishment, conduct disorders. Can you just clarify?
Sorry, I was talking about there's benefits of not smoking. So when you don't smoke, it reduces your level of physical punishment that you impart on the children, and reduces the level of conduct.
You also mentioned Smokerlyzers. If I wanted to find out what my carbon monoxide level was, how would I be able to access one of those Smokerlyzers?
Well, there's different devices on the market at the moment. You can even plug into your phone, which is quite cool. The ones that we have here, I know we're not a face-to-face service as such, but we bring them to community events. So you can access them from the manufacturer's websites.
Literally getting to the end of the question, so thank you everybody for putting these in. What is your advice regarding using the Pico Baby devices currently with COVID-19?
So the recommendation by our governing authorities says that it's not yet safe to do so because of the device, but some clinics may individually make their own choices.
And then we'll take this as the final question, I think. Do pregnant women get NRT for free?
Yes. Yes.